Hello. All right. Is my screen showing? Big green screen?
Not yet.
No? Okay.
I,
Share screen. Try it again. Now?
it's coming up. Yes, ma'am.
Okay, terrific. Well, hello, everybody. I'm so excited to be here with you all live, and then all the people that we hope will watch this amazing day of presentations virtually later. And I'm so excited to present next to these amazing presenters. It's just been really, really impactful to hear these very articulate and open individuals share their stories. And my co-presenters are all people who I have the greatest respect for and lots of love for, as they know. So I'm honored to be here. Um, okay, so when I got asked to talk about comorbidity, I was excited because this is a topic that I've spent a lot of my research life focusing on, along with my BFF and mentor, Dr. Richard Lipton, who has conducted several large, long studies of migraine in the population. And so Dr. Lipton started studying migraine in the 1990s, and he started the American Migraine Studies 1 and 2. And then in the early 2000s, we started the American Migraine Prevalence and Prevention Study. That's when I joined Dr. Lipton. And some of the data that I'll show about comorbidity were gathered in the 90s and the 2000s. And we've been working together ever since then. And we've conducted the CAMEO study under his leadership, the Chronic Migraine Epidemiology and Outcome Study. We'll see some of those data today. The MAST study, the Migraine in America Symptoms and Treatment Study, and the CAMEO-I studies, and the Overcome study. So we have a lot of our data to talk about. So the International Headache Society came to Dr. Lipton and I a couple years back and asked us to create a course for healthcare professionals, for physicians, advanced practice providers, and scientists, all about comorbidity that could be hosted virtually and they could get their CME. So that's a 2-hour presentation. So what I did was take a lot of the good stuff and highlights from that to make a shorter presentation. But you'll see as we go through these slides, these are the same level of scientific rigor in these slides that we presented to training healthcare professionals. So I know that a lot of our listeners are very knowledgeable and have a lot of background experience in migraine. However, please feel free to ask questions. You could put questions in the chat during the presentation. I don't mind stopping during to answer any questions, as well as after. So even though the slides might seem a little complex, I'm going to explain everything as we go. All right, let me move forward. Here are my disclosures. As I mentioned, we have conducted quite a few large epidemiologic studies, and they were sponsored by industry partners. So the American Migraine Prevalence and Prevention Study was sponsored by Ortho McNeil Pharmaceuticals. AbbVie, formerly Allergan, has sponsored the CAMEO study. Lilly has sponsored the Overcome study. Dr. Reddy's laboratory sponsored the MAST study. So I will be talking about data that were sponsored in part or all by industry in partnership with us as scientist researchers. Okay, let's start with a definition. Comorbidity versus concomitant conditions, or things that happen together. So to start with the second definition first, concomitant conditions. These are things that happen together by chance in the same individual. So of the listeners here who have migraine, some of you may drive a blue car. I love blue cars. I don't have a blue car, but I like a blue car. Now, so those things that happen together. You have migraine, you drive a blue car. To our understanding, we don't know or think that having migraine caused you to buy a blue car. We don't think that having a blue car caused your migraine, but they co-occur together. And the way we would test that would be, well, what's the rate of migraine in the population? About 12 to 14 to 15% of adults, depending on which study you look at. What are the rate of blue cars in your whatever region we're looking at? New York City or United States or the world. And then we say, okay, so does someone more likely, are those rates higher of blue car ownership among people with migraine? And chances are they're not, except Now it could get a little tricky. I wish we were in the same room because I would say to you, how can this get a little tricky? Well, what if women like blue cars more and women are 2 to 3 times more likely to have migraine? Oh, now are we seeing a relationship? It may not be causing it, but maybe there's an explanation. But just to give a more simple example, we think that those two things that occur together that really aren't related in any way, we're going to call those concomitant conditions. That's by chance. Comorbidity is when having one increases your likelihood that you also have or experience this other thing, or maybe 2 or 3 or 4 other things. So people with migraine are more likely than the rates in the general population to have X, Y, and Z, let's say fibromyalgia, depression, anxiety, PTSD, allergic rhinitis, just to name a few to start. And if we looked at the rates of depression in the population, about 10% of adults, and migraine in the population, about 12 to 15% of adults, and they weren't related, we'd say, okay, among people with migraine, we'd still expect to see 10% having depression, but we actually see rates more like 20 in the population for episodic migraine, 30 in the population for chronic migraine, 50 and above for people with chronic migraine who see headache experts. So we're going to dive into these comorbidities. Here is a quick overview of some of the studies I mentioned and what we've learned about comorbidities. These are the ones we've identified. Now, you can tell me additional comorbidities that you also think logically you experience or you've seen that maybe we just haven't studied yet. So there's going to be more out there that we haven't studied yet. But we kind of put them in these boxes. These are the ones that we have studied pretty well. So the kind of psychiatric or psychological box being anxiety, depression, post-traumatic stress disorder, panic disorder, bipolar disease, obsessive compulsive disorder. I put 3 asterisks down there to say that having adverse childhood experiences is not a psychiatric condition. It's an experience that is also comorbid with migraine, that people with migraine were more likely than people without to have had adverse childhood experiences. Respiratory, allergies, asthma, non-allergic rhinitis, bronchitis, chronic bronchitis, sinusitis, and COPD. And there may be more in that bucket as well. General pain conditions, joint pain conditions, so osteoarthritis, arthritis, fibromyalgia, chronic pain, neck pain that's not part of the migraine experience, low back pain, some of the central nervous system, insomnia, sleep apnea, restless leg syndrome, vertigo in addition to or not part of that migraine attack, and cardiovascular, angina, having had a heart attack, a myocardial infarction, hypertension, high cholesterol, peripheral artery disease, stroke, obesity, that could probably go in its own category, diabetes. So these are some of the things that we know and have identified by doing that question. Here's the population prevalence of migraine. Here's the population prevalence of this comorbidity. Do they occur at higher rates for people with migraine? These are all yeses. There were some no's. There were some no's in this study. I don't know if I could see the chat, but does anyone want to throw out either something you think is a comorbidity that we haven't studied yet? Or you could put in the chat something you think is not comorbid, and one that was not comorbid, thank goodness for all of us, is cancer. So there were some no's. It's not all yeses, and that's important when we do research, that if we get all yeses, we might say, oh, I don't know if our research is valid. So these are the ones that we know most about. What else do we know about them? We know quite a few things. It probably doesn't surprise anyone listening to know that their rates of these comorbidities are higher with more monthly headache days for people with migraine. So here, if we look at just an episodic migraine, chronic migraine breakdown, you can see across the board that everything is more prevalent, these comorbidities, in people with chronic migraine than episodic migraine. From allergies and hay fever and sinusitis and asthma and bronchitis, Depression, we measured two ways. One is asking that SRPD, that's a self-report of a physician diagnosis. Have you been diagnosed with depression? The other is currently meeting the symptoms on the PHQ-9 questionnaire. The anxiety, have you been diagnosed with anxiety? Now, that's kind of a high bar, actually. A lot of people live with depression and anxiety or the symptoms, but haven't actually been diagnosed by a healthcare professional. So when we look at the symptoms of these, we might see these go higher. The MASS study, the Migraine in America Symptoms and Treatment Study, is one where we did a really nice comorbidity study because not only did we have more than 15,000 people with migraine, we actually had more than 77,000 respondents without migraine. So we could really look at, in those two samples, what conditions, diseases, or symptoms did everyone have and compare. And we compared using logistic regression models. And we looked at two other things to go a little deeper was, one, did the rates, again, continue to increase as monthly headache days increased? EMCM or beyond EMCM, a low frequency EM, a moderate or high frequency EM, a CM. And we also looked, did the rates of these comorbidities change depending upon how intense was someone's typical head pain with their migraine? So the question, when you have a migraine attack, how intense on average is your highest headache pain? So with someone that would say, my headache pain gets moderate, I'm a 5 out of 10, versus someone who says, I'm an 11 out of 10 when I get the head pain. Do they have different chances of having more comorbidities? That one, we really didn't know what to expect. And I'm curious what everyone thinks about that. So here's our first result. Here we can see, comparing everyone with migraine, those 15,000 to the 77,000 without migraine, are there things that people with migraine are more likely to have than the people without migraine? These are odds ratios, OR, and 95% confidence intervals. So the strongest comorbidity likelihood was insomnia. And if we look at that top line, it says insomnia, OR, odds ratios, 3.79. So that means someone with migraine was 3.79, or let's say almost 4 times more likely to have insomnia than someone without migraine. Next one down, depression, odds ratios, 3.18, and anxiety also had that same odds ratios. So we're going to say someone with migraine is more than 3 times more likely to have depression or anxiety or both than someone without migraine. Next, we have gastric ulcer, GI bleeding. That one honestly surprised me. I didn't realize that was going to be in there. Now, if you look back at this manuscript, there was a possibility, a hypothesis that maybe it had to do with people needing to take a lot of over-the-counter medications that hurt their stomach. And our co-author on that is Dr. Stephanie Nahas. That was her brilliant idea. We add that in the manuscript. Maybe that's an explanation. Back to my migraine blue car. Maybe women like blue cars. I don't know. Is there a third something in the mix that makes sense there? But we didn't test it to know if that's the case. It's just an idea. Angina, allergy, hay fevers, epilepsy, arthritis, stroke, rheumatoid arthritis, asthma. These are all more than 2 times more likely. If you have migraine, you have double the chance of having any of these diseases or conditions than someone without migraine. And then, as I said, we went on to say, do these things increase with either number of monthly headache days, that's going to be the bottom row, or your average headache pain intensity when you have migraine attack? And I fully expected the rates to increase with the number of monthly headache days. I was surprised how many of the rates increased with the higher headache pain. So the more intense migraine attacks, which might be a lot of people listening to this presentation. I wouldn't be surprised if you say, oh, that's me. So on the top, we see that top row, we see angina, we see the moderate severe. So moderate headache pain versus the severe headache pain, and we see those odds ratios increasing with the severe headache pain. peripheral artery disease, myocardial infarction, hypertension, high cholesterol. Now, the good news is these are not as common in the population, so that's good. So we're kind of seeing some low rates there. But as we go down to the next row down, now we're seeing that monthly headache days. Do rates go up with monthly headache days? So angina, we see our 5 to 9 monthly headache days, our 10 to 14, our 15 to 20, and our 21 plus. So we didn't even just leave the whole CM, we broke up to CM because I have a feeling that I think, and I bet a lot of you think, that having migraine or headache days on 15 per month is quite different from 30 per month. And a lot of times we had not always broken up our CM group into kind of a lower frequency and a higher frequency CM. And here we can see that it matters. Now, this one is not always the case on the bottom. Peripheral artery disease doesn't seem to go in that real step fashion. That MI, having the heart attack, doesn't really go in that stepwise fashion. Hypertension does, high cholesterol doesn't. So for these cardiovascular diseases, we're not seeing that real strong connection with each monthly headache day. As we go to epilepsy and stroke, we do see this trend continue, that both increase with that headache pain intensity. We see a little bit of a trend with both increasing with those monthly headache days, although it's not a perfect step up for either one. I'm going to show you once we get to the next that really are perfect steps up. Arthritis, osteoarthritis, rheumatoid arthritis, especially. We see rheumatoid arthritis is much more common for people with severe head pain during their headache. And we don't see this real strong trend with the monthly headache days. But we see a stronger trend here in these other medical conditions. So gastric ulcer, GI bleeding, again, if we have that hypothesis that maybe it's related to taking a lot of oral pain medications for a long period of time, maybe that would explain why it would be related to that increase in monthly headache days. Vitamin D deficiency, we see being higher in those with higher monthly headache days. Now, as a reminder, this was a questionnaire study. So someone was just asked, do you have vitamin D deficiency? And so now here's another little potential clue in the mix here. For someone to know that they have vitamin D deficiency, they would have either had to ask their physician, or their physician would have had to test them for that or tell them. And so maybe it is someone who's seen a headache expert, someone who has more frequent headache already, more frequent migraine, someone who's already more kind of migraine knowledgeable. So maybe that travels with a higher number of monthly headache days. Now in asthma, in these respiratory conditions, we're seeing more of a clear step up, both in the asthma as well as the allergies and hay fever with the monthly headache days. So those with more frequent migraine headache are talking about those asthma and the allergic symptoms. And we see psoriasis being more common with the high headache pain. And here are anxiety, depression, and insomnia, where we really see the clearest trend for both questions. Rates increase with average headache pain intensity, rates increase with monthly headache day intensity. So in some ways, anxiety, depression, insomnia, one, if you remember, they were the three most common with the highest odds ratios, your highest chance of also having these if you have migraine versus someone who doesn't. And they seem to really interact with the migraine in important ways. They seem to be strongly influenced by migraine. So as we go forward, I'm going to go a little deeper into some of these and try to figure out why are they so interconnected. So let's talk about ways that these comorbidities or these conditions can be connected. The first one we already talked about. Comorbidity may rise by artifact, coincidence, or selection bias. So, the coincidence being you have migraine and you live in the city you live in. And you're all in different cities probably, so, or, spread out across the country probably. So that might be a coincidence. Although there could be some selection bias there. There could be something in that environment. There could be a lack of healthcare resources where you live. Or maybe you live in downtown Boston or New York and you have a great hospital on every corner. So maybe you have more health care and you've been diagnosed and treated. Um, or selection bias. Perhaps we did a survey when people were getting their mammograms, and then we were surprised that almost all of our respondents were women. And then we would say, okay, well, maybe we need to do a survey at a place where men and women are coming equally for healthcare. So these three kinds of reasons. We try to figure out what's those clues that are related to both that probably aren't causal inside the genes, inside the nervous system, or in the environment. Then there's unidirectional or bidirectional. One thing causes the other, or each one increases the odds of having the other. Then there's these conditions may be related due to an shared environmental or genetic factor. So let's say we're talking about veterans from a foreign war and they come back and they have both X and Y, and it's because their environment was 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 dangerous and either had certain chemicals or it had unexploded, explosive devices, and they come back with both post-traumatic headache and PTSD. We're going to say, okay, both of those are coming from the environment of being in that war. But it can also be genetic factors. There are things that have genetic predispositions that arise in more than one condition, and those conditions go together. Or the most complicated is we may have those genetic risk factors, we may have those environmental risk factors that does something to our brain state. And when it comes to migraine, it is activation of that trigeminal, remember the trigeminal nerve, 1, 2, 3, vascular being the blood vessels system. The trigeminal vascular system is our system that's so involved in migraine. It gets activated and turned on, and is hyperreactive for not only someone with migraine, but also as migraine progresses, as it becomes more frequent, more intense, more, um, more. Obviously, we saw the stronger headache intensity, more symptomatology, a longer duration with the activation of the trigeminal vascular system. So a lot of what we see as the comorbidities are probably this more complex interaction, your genes with a certain predisposition, your own biology. Are you male or female? Is it related to hormonal cycle? Are you pregnant? Are you postpartum? Are you perimenopause? Are you a veteran who was exposed to trauma in war or trauma in adverse childhood experiences? What are all your personal variables that set the stage for your personal list of comorbidities? If anyone has questions, I am happy to answer them. I know that was a lot, but I think it's important that we set the stage for how we carefully think about comorbidity and what my colleagues and I have studied. So I do see there's one note in the chat. Let's see. Oh, no, that was just reminding us the break was almost over. Okay. So we've done a lot of research in migraine and depression, and it's probably our most studied comorbidity dyad. And so I want to tell you a couple interesting things about it because it helps us understand even more. So here are two different studies done in two different populations. One was in Baltimore, one was in Detroit, and these were in the late 90s and 2000, where um, through questionnaires, people were asked about various psychiatric conditions. And here we have our adjusted odds ratio. So once again, the way to read this is if we look at the first line, major depression from the Baltimore Economic Catchment Area Study, someone with migraine would be more than 2 times more likely to have major depression than someone without. And the Detroit study has a 3.6. Someone with migraine would be 3.6 times more likely to have depression than someone without migraine. We see panic disorder even stronger with a 3.4 or 4.9. That's almost 5 times if we look at that Detroit study. Someone with migraines 5 times more likely to have panic disorder than someone without. And panic disorder If you're not familiar with it, is attacks coming from out of the blue, where there's sympathetic activity. The heart pounds, it feels like you can't catch your breath. Might feel like the throat is closing in. There's a feeling of a fear, anxiety, and intense fear, even like someone might die. And it can come from out of the blue, or it can come from a specific stressor or something in the environment. That's panic disorder. Often, along with panic disorder, someone may develop agoraphobia, where they avoid certain situations or even feel afraid to leave the home or do certain activities or be in large open spaces, crowded spaces. We can see that agoraphobia has these odds ratios that is comorbid with migraine. Social phobia, simple specific phobias. A specific phobia could be heights or the dentist or spiders or clowns. I don't like clowns. And any phobia. So we can see that all of these conditions, all of these psychiatric diagnoses are comorbid with migraine, meaning someone with migraine has a higher chance of having these conditions, any of these conditions, than someone without. Since this research has been done, we also have added more knowledge with understanding that PTSD, as I mentioned, bipolar disease, um, um, and not a psychiatric condition, but the experience of adverse childhood experiences or trauma, being in war, being in living in a dangerous area, or having scarcity of food or necessities. Any of those things have also found to be comorbid with migraine, sadly. As we talked about, the rates of depression, like some of those other conditions you just saw, increase with the monthly headache days, starting from about 10% in the general population to 17% of those with migraine in our population survey of the AMPP study, and about 30% of those with chronic migraine in our population study. Then if you survey people who are actually seeking care, especially if you look at those who are seeking care in a tertiary clinic, tertiary meaning third, so we would think of primary care as first, a neurologist as second, a headache expert as your third. If you look at that third group, we're going to see rates of depression or anxiety or both above 50%. Now, why is that? Probably because people with worse disease are seeking care, which is what we would hope. So we see that step up. Now, this is really interesting and important. We talked about something can be unidirectional. Someone has X and then they develop Y. But we see that migraine is bidirectional. So it probably is not surprising that if someone had migraine first, their odds ratios are 3.4. You want some? Wait, hold on 1 minute. Let me make sure I'm not reading the wrong side. Yes. Okay, let's look at the right side first. I'm going to tell you the obvious one first. If someone had migraine first, if we look at the odds ratio of 5.8, the blue on the right side, their odds ratios of 5.8 that we're going to see depression within the next 2 years. 2 years is not a magic number. It's just how long the researchers chose to follow up. And that was Dr. Naomi Breslau and Richard Lipton. So this is not surprising. So if someone has migraine, they were 6 times more likely to see depression within the next 2 years compared to someone who didn't. That's that unidirectional. But if we go back to the left, to the red side, this is interesting. If someone has depression, they were 3.4 times more likely for migraine to, I wouldn't say develop, I would say kind of start occurring in the next 2 years. And it's pretty easy to say, okay, well, you have migraine, you get depressed. It's frustrating, it's painful, it's unpredictable, it's this awful condition that affects your life in all these ways. So kind of thinking of migraine experience causing depression. But we can't really do that same experience in the other direction, the experience of depression causing migraine. So now we say, okay, what else is it? Well, there's quite a few things that are going on. One is that there are the same neurotransmitters involved to some degree in both of these disease states. They're highly active with serotonin and other neurotransmitters that are active in both of these disease states. So that's one thing that could be going on. The second could be genes. We know that migraine runs in families. It has a genetic predisposition, as does depression, as do some of the other psychiatric comorbidities that I mentioned, and other comorbidities as well. Cardiovascular disease runs in families, and diabetes runs in families, and so many diseases have a genetic link. So there's quite a few reasons that this is not surprising, but I still think when I present this at first, people are not surprised to see the migraine first, then depression, but it's a little more surprising to see the depression first, then migraine. And what was very interesting is Dr. Breslau and Dr. Lipton then said, is this also the case with non-migraine severe headache? And it wasn't. So it only went one way with non-migraine severe headache, that people with the severe headache that wasn't migraine type were more likely to develop depression within the next 2 years, but having the depression were not more likely to develop another type of severe headache that wasn't migraine within the 2 years. So the two ways is the migraine and depression, or the whole shared underlying causes. Let's talk about stigma a little bit. There's been more stigma research coming out in the past few years, and I think this is really important. We are starting to see stigma as maybe a missing key to understanding and unlocking migraine solutions. We know that stigma is common in migraine, and it's associated with quite a few things, so including comorbidities. So in our New York clinic-based study that my colleague Betsy Sang led, we surveyed patients at several New York clinics and found that higher stigma scores, we used the SSCI-8, that's a stigma questionnaire, were associated with the higher migraine monthly headache day frequency, higher disability, that's our MIDAS, higher allodynia, that's the ASC-12. You can see that all down there in the left box. And allodynia is something that shouldn't normally hurt on the skin or the hair hurts, a ponytail hurts, a hat hurts. A higher pain catastrophizing score. Catastrophizing is that experience of thinking the one thing and what about this and what about that and what about that, and it's going to be terrible, and coming out to the worst possible scenario. And it's easy to think that way when you are living with a chronic, painful, unpredictable condition that is wreaking havoc with so many important areas of your life. Higher anxiety and depression, that's the PROMIS A/D, that's our anxiety depression subscale, and lower migraine specific quality of life. And then we also looked at stigma in the Overcome study, where we surveyed almost 60,000 Americans with migraine and found that, again, it was highly associated with disability. Disability meaning how's it affecting work, school, social, family activities. Highly associated with interictal burden. So even between attacks, for people who have between attack times, are they worried? Do they plan their life differently? For example, not make certain commitments, worry about if they're going to be able to fulfill certain commitments, whether it is a fun social engagement, a family engagement, or a work commitment, and worse quality of life. Well, in addition to this, as I mentioned, we do see that stigma is related to, let's see, there we go. We do see that stigma is related to psychiatric diseases and comorbidities. And I saw that a questionnaire just came up. So should I pause and give everyone a moment to fill out the question?
I'll leave it up there for a little bit. Go right ahead.
Okay. Okay, and I'm going to jump into, while we leave that up for a minute, let me jump into the chat for a minute. So So I see JP has a question. Hi,
No,
JP.
we're good. We're good right now.
You want to leave those to the end?
Yeah, that was actually just a question about a previous presentation. So,
Oh, that's previous.
yep,
Okay.
not for you, but we'll get there.
Okay.
Great.
All right. Okay. So, so several studies have shown both in migraine as well as other disease states that people with higher social stigma are much more likely to have more psychiatric symptoms. And I think this is an important thing for me to kind of clarify and remind people there's a lot of levels when it comes to having depression or anxiety in terms of recognition and diagnosis. Um, Seems a little more straightforward with diabetes or high blood pressure or um, another kind of test that there's a lab test that's really easy. Like depression, anxiety, migraine, all three of these, we don't have easy lab tests. They're really about conversation, your doctor or your healthcare professional who's giving the diagnosis, getting to know you and all of your symptomatology, and finding out if you meet those particular criteria. And a lot of these comorbidities I've mentioned, the rates are probably even higher than we're seeing because a lot of these are probably undiagnosed. A lot of people experience insomnia, but maybe don't talk to their doctor about it. And a lot of people experience symptoms of depression and anxiety, but have not either talked to a doctor about it or it might not meet that level that it gets a diagnosis, but there's still symptomatology. So when we do a lot of the studies that we've done, we will measure the symptoms as well as asking, have you gotten a diagnosis? And there's different range of symptomatology. So even if someone does not meet a diagnosis for major depression, they may still have some of those symptoms. The two first symptoms of depression are feeling down, sad, or depressed most days. And the second one is anhedonia, meaning things that you usually enjoy, you just don't enjoy. Are you doing your hobbies or your social activities? Are you looking forward to an event, a holiday, a vacation, a party, something at work? As you kind of lose that joy, that excitement about life, that that enjoyment of certain things, that's anhedonia. It's not really enjoying life like you typically do. Those are the first two hallmark symptoms of depression. And then there's other symptoms like having low energy and either having a very low appetite or overeating. There's other symptoms as well. And some of those symptoms overlap quite a bit with the anxiety symptoms, and they overlap quite a bit with migraine symptoms. So it actually can be a little hard to disentangle. Is it migraine? Is it anxiety? Is it depression? Is it all of the above? So you'll see in quite a few of our comorbidity studies that we measure symptomatology from no or low depression or anxiety symptomatology to kind of a mild to a moderate to a severe. And we may all experience changing levels of depression or anxiety as we go throughout our life that may not always meet that full threshold, but they are still affecting your quality of life. Okay, so we have our poll results. And it's understanding comorbid conditions. What do you wish you understood more when it comes to migraine and comorbid conditions? So we've got how comorbidities influence migraine symptoms and severity. We've been talking about that. The connection between mental health and migraine. So we'll talk about that some more. How to talk to healthcare providers about multiple conditions. That's great. I'm glad you let me know. And it looks like that is the biggest response, the biggest endorsement there. And treatment options that address multiple conditions at once. And I'm going to talk a little bit about that too. So we've got some more things coming. All right. This has been a lot of information. If you do have questions now, please feel free to post them. I'm very happy to clarify anything that I've talked about. I want to make sure we're all still together. And feel free to do that. I'm going to jump into our next section. So starting to think about clinically, what does this mean? One thing that we think a lot about is migraine worsening. And it could be progressing from episodic migraine, migraine with 14 or fewer days on average a month with headache, to chronic migraine, migraine with 15 or more days on average, of which 8 are related to migraine. And this is another area that Dr. Lipton and I have done quite a bit of work with our colleagues, Dr. Michael Reed and Dr. Tina Fanning, through the CAMEO study, the AMPP study, math study, and Overcome study. Is there a clue that gives us an idea that a particular person is more likely, even though they have episodic migraine now, to have chronic migraine in the near future? Well, it turns out everything on this slide we have identified as being related to that progression. Again, it might not mean causing. It might mean that they are both part of they're both related to a shared cause. It might mean that they are interacting with each other. It might mean that they are both exacerbating each other. So in the comorbidity space, if someone with episodic migraine 1 year also has depression or anxiety, bipolar disorder, also obesity, asthma, sleep disturbances like having sleep apnea, head and neck trauma, other chronic pain conditions like fibromyalgia, low back pain, cardiovascular disease or history like a heart attack, metabolic syndrome, which is related to both obesity as well as inflammation. Oops, did not mean to go forward. Or multiple comorbidities, kind of a constellation of comorbidities. They have a higher risk of having chronic migraine or progressing to more frequent migraine in the future than someone who does not have those conditions. We also found that that progression was related to the experience of stressful life events, higher caffeine intake, and higher was actually more than 181 milligrams per day, which is 3 cups of regular coffee, old-fashioned diner regular coffee. Lower socioeconomic status, physical inactivity. Also, not surprisingly, as migraine became more frequent, as someone had 12 or 13, 14 monthly headache days, they were more likely to move across that 15-day threshold. But also some of the symptoms, persistent frequent nausea. And there are also treatment and allodynia. So if they have that sensitization of the skin, if a ponytail hurts, wearing a hat or a headband, shaving, wearing glasses during attacks or even between attacks, that's allodynia. Things on the skin or hair hurting that don't usually hurt, we call it cutaneous allodynia actually. And then we also found that acute treatment not being optimized and overusing acute medications or medication adaptation syndrome was also associated with progression. Now, this matters to us because we love to find ways we can intervene. And we don't actually have a study where we intervened with one of these and found a lower rate of progression because we would need a massive study. So we found that in the population, about 2 or 3% of people who have episodic migraine 1 year have chronic migraine the next year. So in order to design a study and treat any one or multiple of these, we would have to have a pretty massive intervention study to show that that 2 or 3% went down lower. Now that's the population. When we look at our clinics, we see much higher rates of progression because we're seeing people with more severe disease, people who are seeking treatment because migraine's interfering with their life. And that's where we would really want to say, does intervening with these decrease the risk of progression? Now, logically, treating all of these things is a good thing to do for one, just everyone's well-being and quality of life. And 2, theoretically, it makes sense that anywhere we kind of help calm this trigeminal vascular system and decrease the activation of the nervous system is good for the whole system. So because I said we know the most really about depression and migraine as a migraine comorbidity, here's something else we saw with depression. When we look at rates of progression from episodic migraine 1 year to chronic migraine the next, not only was having depression a risk factor, but that risk increased with the severity of depression. So those with moderate depression, depressive symptoms, had 1.8 times odds ratio, almost 2 times more likely to progress to chronic migraine than those with no depression. Those with moderately severe, their odds ratio was 2.3, and severe was 2.6 times more likely to progress the next year than those with no progression. So before we looked at this step up in rates of comorbidity by monthly headache days and by average headache pain intensity, now we're looking and seeing these same steps of risk of progression based on depression intensity. We don't have these data for the other risk factors that are known simply because we hadn't done the studies yet, and we, of course, would like to. But we know this, and so it would be very interesting to see if we see these same increase in progression risks with increase in comorbidity severity. So we talked a lot about migraine and depression. As I mentioned, it's really the comorbidity dyad we know the most about. It's complicated. It is associated with monthly headache day frequency, associated with headache pain intensity, and associated with progression. And there has been this myth that people with depression and migraine are difficult to treat. And you will see that written in scientific studies, publications, and manuscripts, even manuscripts that I'm a co-author on, even though I have always been trying to say this is not the case. But we didn't always have the data to show it wasn't the case, but now I'm going to show you that we do. In good news, as migraine improves with treatment, as we see in migraine preventive trials, depression also improves, as does anxiety. And we don't know that that is directly related to the migraine treatment. Is it related to the migraine activity reducing, or is it related to some shared underlying state like the activation of the trigeminal vascular system, and also the the HPA axis, these systems that are activated in migraine? Is it kind of calming and quieting those systems, and it helps multiple comorbidities? And we think that that might be what's going on. And that's why it's important, if you're living with comorbidities, to think about talking to your doctor about all of them. Even when you think, I don't know if this is related, I got to tell you, as a researcher, I'm continually impressed with all the things that we find that are related. There's quite a bit that is related. So it doesn't hurt to let your doctor know everything you experience. And either that doctor can treat you, or he or she can refer you to the best person to get treated for that comorbidity or that condition or that risk factor. So now I want to talk for a moment about conditions that occur together. What comorbidities cluster together? So there's some natural groupings, which will probably not surprise you. So in the CAMEO study, we put all of our comorbidity data in there together, and we used latent class analysis to see which naturally kind of occur together. And we found there was about 8 different groups that occurred together, suggesting there's some either biologic similarities, some genetic similarities, some neurotransmitters shared, some environmental reason that they cluster together. So chances are, if you have more than 1 or 2 comorbid conditions, there's some reason that they are occurring together. So we had more than 12,000 people with migraine in our CAMEO study. In CAMEO, we surveyed people every 3 months. And so we were able to do a nice longitudinal study for 15 months. And in one of our 3-month surveys, we went deeper on comorbidities and asked about oodles of potential comorbidities. And then of these 62 comorbidities we asked about, we threw them all in our latent class analysis. And we found there were 22 comorbidities that really didn't join into a group. They didn't discriminate between the group. And so we did not keep them in, and we ended up with these 8 different groups. And the first one we'll call the most comorbidities. People had quite a few comorbidities, and class 8 we'll call the fewest comorbidities, meaning zero, maybe they only had migraine or just one comorbidity. But some of the other things that grouped together was respiratory and psychiatric comorbidities, respiratory and pain comorbidities, respiratory on their own, the psychiatric or psychological comorbidities on their own, the cardiovascular comorbidities on their own, and the pain comorbidities. Again, the pain could be fibromyalgia, it could be low back pain. There were some other pain comorbidities in there. So these are the naturally occurring groups. And we found that that if we look at fewest comorbidities being about 1/3 of the sample, 2/3 of the sample had a cluster of comorbidities, showing how common it is to have more than one, migraine and one other. 2/3 of the sample had multiple comorbidities that occurred together. And here's a little bit about these different classes. We can see that most of our sample was female, but when we look over here in class 6, we can see that that has the lowest percentage of female or the most percentage of male. And that's our cardiovascular class group. And that's not surprising. Cardiovascular events are more common in the population in men than in women, especially at the younger ages or the middle life. And we could see that that also is the older group by about 13 years older than, for example, group 2, which is our respiratory psychiatric group. We can see different rates in BMI, different rates of allodynia, different rates of people who had aura, and we see that these groups are a little bit different. And this isn't surprising. So based on kind of this profile of comorbidities, there's a certain profile of patient, maybe male, maybe female, more likely, maybe a different BMI, more likely to have aura, more likely to have disability. And so when we looked at disability, we saw that the people with the most comorbidities had the highest MIDAS grade. That's the Migraine Disability Assessment Scale. And grade 4 is severe disability, severe impairment at work, school, family, social, and chores. We can see that almost half of people with this most comorbidity classes are severely disabled in their life. It's not surprising. This is kind of one of those findings that duh. Nonetheless, we have to publish these findings because we need these data when we go do advocacy, when we ask for funding from government agencies for research, when we want payers to pay for our treatments. We have to have this scientific data out there in the literature, published in peer-reviewed articles, so we could say, look, how impacted, how impaired people are with migraine alone, let alone with migraine and comorbidities. So that was one of our important findings. And these are our models of progression. Were there different rates of progression for people who had episodic migraine at one survey to chronic migraine next survey? And in fact, yes, if we look at the line in red that says most comorbidities, and we look over to the right, step 8 forward, that's our final model where we include all the potential covariates, we see that people with the most comorbidities were 3 times more likely to have chronic migraine at follow-up than those with the least comorbidities. So having the most comorbidities matters in quite a few ways and really impact these people's lives as well as their progression.
Donna, I'm gonna jump in here. We are just about at we actually are at time right now.
Okay.
So if there was a point you wanted to like make sure that you were able to share with with everyone, I'd love to be able to kind of
Well, this is a great point actually, because I'd like to end on the what can we do about it?
Right.
And what we do need to do is all the things. So we need to make sure that when we see a doctor, we are optimizing our treatments, our pharmacologic treatments, our non-pharmacologic treatments. Don't be afraid to tell your doctor all of these symptoms and conditions, even if you think, I don't think that's related. It really might be. Um, and try to get treatment, manage all these comorbid conditions because the data show us when you treat one of these, others get better. When you treat migraine, several of these improve, and we hope that when you treat the other comorbidities, migraine also improves. So also remember your healthy habits, things like good sleep, staying hydrated, eating a low inflammation diet, managing your stress, and enjoying your life to the best that you can. So I'm happy to end on this. What can we do about it? More optimistic, knowing that any way you treat migraine, comorbidities get better. Behavioral treatments, traditional oral medication preventives, and CGRP targeted meds have published data that not only does migraine improve, but depression, anxiety, and other comorbidities improve. So thank you. I know this was a big, heavy topic, and I thank you for inviting me. And I got to present to you the same topic that we present to headache doctors around the world. So thanks for hanging in with